Well, I like the thought that I think Whitney left us with, that the food system should be viewed as not charity, but as infrastructure. And if you've been here through the morning, I guess I had a whole paragraph written out, but the bioeconomy needs to be utilized in certain ways. The one theme that kind of stuck through it all reminded me of a line from Jerry Maguire. Was it Jerry Maguire? Show me the money, right? It's profit and loss. And I think we learned from the last session that food as medicine is not a departure from that at all. In fact, I would say food as medicine is the demand side of this food system, or change in this agri-system. It's what happens when the food system connects to the health system. And when that connection is designed intentionally, it generates jobs, local revenue, community wealth. You've seen the headlines about food as medicine. We're going to dig into that a little bit more today, but we will arrive at a question that we'll get back to. But I want to welcome my panel members who represent different domains in that kind of cycle. Emma Savings with UT Southwest Culinary Medicine, Waldo Amenashoa with Dallas County Health and Human Services, Bené Watkins Chambers, CEO of Crossroads Community, and Todd Ichinaga with UT Southwest Food Services. Each of these panelists are experts in their space. Each of them kind of take a different part as being a practitioner and different kinds of action to make it happen. But getting back to the question, what if a single policy decision made in the state in this decade could simultaneously reduce hospitalizations, create thousands of jobs, build career pathways in communities that have never had them before, and generate measurable returns on public health dollars, and transform the way one of America's largest healthcare markets sources its food? And what if that decision didn't require new money, just a different way or a different approach to that money about how that existing money flows? And this isn't just a hypothesis. Can we advance the slide, please? Does this clicker work? As we see, food is cheap. Compared to other countries in the world, Americans pay less for food than anybody else. But what is that buying us? It's a health system overwhelmed by conditions that are largely preventable, with no prevention infrastructure, no career pathways, and absolutely zero return to community wealth. So it turns out cheap food is not particularly cheap. We as a country spend more, arguably, conservatively, $1.1 trillion every year on diet-related chronic disease. And that money actually is being spent right now in this city, in this county. And disproportionately, in some parts of the city where poverty rates just go well over 30%, food insecurity abounds, 1 in 5 children go hungry. This is some of the data that shows that if a fraction of that $1.1 trillion was redirected upstream, what if it grew food locally that could prevent these diseases? Last month, as you see, and we saw earlier, the Rockefeller Foundation published a report, From Farm to FIM, the economic impact of local food as medicine. It found that every dollar invested in food as medicine returns on average about $3 in healthcare cost savings. I don't know what you think, that's a pretty good return on investment. We should not stop for a moment to think that food security is not just hunger. I'm going to turn now to Emma Savings to talk about culinary medicine and describe what it is within the context of what we're doing.
All right. It's great to be here today, everyone. My name is Emma Saving, and I am the UT Southwestern Culinary Medicine Program Coordinator, and I have a public health and biology background. So my team and I conduct clinical and community research on practical nutrition interventions using food as medicine principles. In culinary medicine, we actually teach people how to cook nutritious food that corresponds to managing a diet-related disease. So for example, when we have a patient class with many people with diabetes, type 2 diabetes, we'll have a bunch of recipes that deal with stabilizing your blood sugar. So you can see some of the bullet points that we have up here. We do, again, hands-on nutrition education. That's for patients, community members, and medical students, dietetic students, public health students, people who will be leaders and clinicians in the health profession space. Our recipes are designed to help manage and prevent chronic disease, diabetes, hypertension. Brad mentioned cardiovascular disease, which is the #1 killer of Americans and Texans. Each of our classes includes both nutrition education from my physician and dietitian colleagues, and then we have a cooking section where we get into the kitchen. As my dietitian colleague loves to say, it's not nutrition until you eat it. So yeah, we teach people how to make healthy food that will help them manage their chronic disease, delicious, easy to make, so breaking down some of these culinary literacy and health literacy barriers. We do a lot of interprofessional collaboration with many people in the medical and academic fields, research, public health, and as well as community partners. And we really have a great focus on community engagement, including with some of my colleagues here.
I want to back up a moment because there's some points I want to make here about food insecurity. Food insecurity is more than just about not having food. There's chronic stress involved with that. I learned a term called allostatic load, and this has a biological reverberations, I guess, at biological costs. Over time, the cost shows up as heart disease, diabetes, obesity, and cancer. And this shows the mechanism by which poverty becomes disease, and that there's a cost to that, of course, and it costs all of us. And food as medicine is the intervention that breaks that cycle and is designed intentionally to do that, but it's also an investment that pays for itself. And the question isn't whether this works or not. The question is whether we have the will and policies to build it to scale that the problem demands, and to stop treating these costs as inevitable losses and instead recognize them as investments that not only return dollars, but allow us to actually realize not just health and social benefits, but also economic benefits. And the people here will help us share those thoughts. I want to bring into the conversation B'nai and perhaps Emma to talk about the program they're doing at Crossroads as kind of an example where you are, where you'd like to be, what some of the challenges are, if you would.
Sure. Thank you all for having all of us here this morning, but certainly myself representing Crossroads and the work that we've been doing in this sector with Emma and the team of physicians and dietitians. In May of last year, so just a year now, we opened our nutrition pharmacy at the Shops at Redbird, which is designed to serve as a co-located space for nutrition support for the healthcare entities that are there, which is Parkland and UT Southwestern and soon to be Children's. And the way that program works is that the dietitians primarily and the social workers will refer a patient who has been diagnosed with one of the chronic illnesses we've been talking about, and even some cancer infusion patients, specifically from UT Southwestern, who need nutrition support as part of their health care. And so the first line of defense that we provide is really a continuation of the education that they received at their clinic visit. But then we also provide them with the actual food. So they come for 2 visits per month over an 8-month period. That first, they get a full complement of food for the household, not just the patient. That's a distinct difference from the FoodRx program you might hear about to the way we provide support. And then they come back for a second time for just produce only. And the reason we do that is because oftentimes we have learned that while people want the produce, they don't know how to store it. They underestimate how fast it may not that it'll go bad, or they overestimate how much, or underestimate how much they will actually consume. And so this is also a way to teach them about consumption, about its usage, storage, and ideally helping them avoid waste. But then the third prong of that work is really the culinary intervention. And so we have a culinary classroom, as you can see here, that's actually designed in our space in partnership with the UT Southwestern team. I don't know why we're using that picture, that's me. But we were having a class with our staff. But we've also had classes with community members, and we have our another one coming up on May 5th. And these are patients that have now gone through our program and are now needing the culinary intervention. And that is so critically important because many of our families may not try something because they've never tasted it, or they tasted it, but they never knew where it started. So it doesn't look like what they thought. They don't know how to prepare it culturally relevant, which is really critical to populations that are predominantly Hispanic and African American. You need to make the food taste somewhat similar to what they're used to for the ongoing consumption. And then additionally, this is about using kitchen tools. We have stopped cooking as a country, really, and so reintroducing the kitchen to families and communities, knife skills, how to mix things, how to use, a cooktop that is not a traditional stove, because we also have to remember that many of our families don't have access to those types of tools. So it's really a great partnership. We're enjoying how it's starting off. And our biggest challenge is just ensuring that people really understand what it is and how it works. And our biggest opportunity is doing it more, reproducing this work and this partnership in other locations, not just with Crossroads, but across the community at large.
How many people participate in the program?
So currently, we are seeing between 25 and 40 patients a week that are coming into our pharmacy, and that really depends on referrals. And then we see in our classes, we're just kicking those off, but our next class is actually booked already with 15 people. It's probably more people than I think but that's because it's on Cinco de Mayo and it's Taco Tuesday. So we were totally expecting that it would be full, but we can hold up to, I believe, 16, Emma, in those classes?
I think so.
How could you scale that, and what would it take to do that?
A kitchen, honestly. We are in the process of actually scaling it. We have a commercial kitchen in our main site. We're opening a third site in the Esperanza project up in Richardson that also has access to a kitchen. And I would say, one, you need a kitchen, and two, you need trained staff, because it's not just here's how you cook, it's here's how you align what you're preparing in terms of the food with the healthcare needs. And obviously, we need to make sure that there's a partner who's providing the primary amount of food that the family needs.
Well, we might get more to the cost. Going back to the map, one of the most impacted areas, I might toss the ball to you all to talk about what it costs the county for health interventions, to kind of put a number on what savings could possibly be.
Thank you for having me here. My name is Waldo Amaneshwa. I am Assistant Director of Chronic Disease Prevention at the Dallas County Health and Human Services. As you all know, the mission of Dallas County Health and Human Services is to protect and promote health of Dallas County residents through intervention, through prevention, community education, as well as environmental kind of regulation or improvement. So as we do this, we have different human as well as health services that we provide through our different departments. And one of the departments or the divisions is a division of chronic disease prevention, which I am heading. So the chronic disease prevention division does a lot of activities to prevent the main chronic diseases that are impacting our community in Dallas County. Some of these include diabetes, hypertension, which is a primary factor for cardiovascular diseases, as well as obesity, cancer, and others. So if you look into the main chronic diseases that are impacting our community, most of them are diet related or food related. So because of that, from the get-go, the Chronic Disease Prevention Division designed a strategy where we should go after the factors that food security is one of them. So the 4 main factors for chronic diseases or prevalence of chronic disease in the county or in other places as well are food insecurity, smoking, alcohol use, excessive alcohol use, and physical inactivity. So our division is heavily involved in at least 3 of these factors, which is smoking, physical inactivity, as well as food. When we come to food, we designed a strategy, we call it 3 A's, which stands for availability, access, and awareness. In the availability area, we try to increase local food production, or we want to increase healthy food availability in our area. The second is access. Access, I think one of the previous speakers mentioned that access is not only just access or availability of food in the area. Access, physical access where you have stores nearby where you live, and also access in terms of affordability. So we are looking into that as well. And lastly, we also educate not only producers in our area in terms of our urban agriculture, particularly gardening, but also residents to produce their own food, and also potentially, get into the commercial side where they can also improve their income. So we're really heavily involved. We partner with a lot of local community partners as well in this respect. So when it comes to, I think, the disease burden, if I just mention few numbers, hypertension, for instance, is the prevalence of hypertension in our area is 31% to 41% of the population has hypertension. And this number is even higher among older adults or senior citizens. When it comes to diabetes, 11% to 17% among the general public. Cardiovascular disease, 5 to 8%. This is particularly heart disease. Earlier, one of our speakers said that heart disease is one of the main cause of death, or the number 1 cause of death in our area. And diabetes is also one of the top 10 cause of death in Dallas County. Similarly, obesity has 30 to 41% prevalence in our area. As you can see, all these chronic diseases are diet related. So any activity or any inactivity in supporting the food system in our area directly impacts the prevalence of these diseases.
Walter, I have some numbers here, and
Okay.
you'd probably agree with it. A federal study costs about $1,000 per American adult per year. So if you take the 2.7 million Dallas residents, that's costing us $2.7 billion a year. That's money flowing out of the county that could be going back in. But I'd like to return to the food as medicine, and particularly the procurement part of it, which Todd, I think, has a lot to say about it. We're working together on this. The UT system, of course, is one of the largest employers in the state, and one of the largest food buyers in the region. And I guess I would call you you'd be anchoring the demand side of this potentially, or an example. So it's the first door we've had open for a large institutional buyer that creates a platform for other small ag companies or producers to sell into. So maybe speak to our relationship a bit and your thoughts on that, if you would.
Sure. Thank you. I'm humbled to be sitting on this and sharing this stage with my colleagues here. So thank you for having us. What are we doing? Why am I here? I run the campus side of UT Southwestern's food program. And what that looks like for us is we get to serve on average about 2,500 faculty, staff, medical students every day. You know, that's not including catering. If you factor in catering, that can double. So we have a small footprint on the campus. We're not the hospital where they're feeding 24/7, 365. But what we did was we started off to reset the food system that we have here in DFW. And where does that start? It starts with getting like-minded groups together that can move towards the same goal. And what that is my food service provider. I asked them, can we work towards making Restorative Farms an approved vendor for us? The quick, easy way around that is to purchase on a P card. But what we're looking to do is create the blueprint for what is sustainable and then scalable beyond that. So that, us being in one of the largest food deserts in the nation, then the next group, if we're open source enough, we can then share this information and what we've learned and what we're doing with the next city, with the next state, to work towards a more holistic solution. And in that whole process, so Brad and his team have graciously gone through the procurement process, so now we can include them in our supply chain. We're not trying to go around the supply chain and cut corners. If it were easy, everybody would be doing it, right? But we're here to do the hard work, to put in the hard work to make that happen. So I would say that this is kind of a great model for us. The institution is us at UT Southwestern. We're creating the demand. Brad, as he is the local farm, we've gone through the procurement process. My group is the auxiliary restaurant group, and they are the ones that have the culinary talent to be able to take Brad's product and put it into our cafes, to put it into our grab-and-go salads, our sandwiches, our entrees. And then we can also work with Benet and with Emma and help them with our culinary talent to be able to come in and to assist with the technical aspect of it. So then you get into more community, right? We're building community. We're giving back to Restorative Farms. We are creating more jobs. And then the last component to kind of close the loop on this is that we are working with Moonshot, who's our composting company. And we are looking at how we can not only divert our compost to Brad's second farm at Longview for vermiculture, but we're also working on other really cool things like a fermentation lab to reduce the amount of input into the composting. So that kind of sums this slide up for you.
And we're just at the start. The question is, how do you eat an elephant? One bite at a time, and this is our start. We're working through it, but to repeat the numbers that the Rockefeller Foundation said that would impact Texas farmers, if this system could work, farm to food is medicine, buying locally grown organic food, that's $315 million in revenue for local farmers, 30,000 jobs, a $3.86 billion increase in Texas GDP. And you think about all that money, instead of flowing out of the state, flows through the local food system. So I guess to sum it up, the regional agri-systems are built, if they are built with intention and smart design, they don't just work, they generate prosperity and resilience. And that opportunity is no longer something that needs to be proved. It's already been proved. We have a model that we're working. It's time to legislate it, fund it, scale it, and make it the default. What this panel has added to that is that human component, that the human infrastructure underneath the economic infrastructure. And when you build that intentionally, community benefits compound. And here's that number again, $11.06 billion. That this is a real measured number based on a lot of research. It's for real, so we don't need to wait for proof. We have the proof already. What we're waiting for is the policy and the will to make that happen. So we have a minute or two for questions. Are there any questions, or go ahead, please?
There are programs. Actually, there's a really great one in San Antonio. The San Antonio Food Bank does a chef program with their children. I know that DISD has some programming that they're looking at to launch. It's very small at this time that I'm aware of. I know we've talked about it too, but bringing home ec back into particularly middle school and high school is a game changer, I think, for just teaching nutrition. And yeah.
Well, that is an issue, right? It's more than food access is what you do with it. And as you know, Waldo, people are often given food. What are some of the challenges they have with it, even when they have it?
Yeah, thank you. So food is not just nourishment, as we all know. It's also culture, it's also behavior. So one of the main challenges we have is at times changing people's behavior so that they are also given the access, that is, they are also aware of the health implication of what they eat. So behavioral change takes a lot of time, even if there is availability. So the earlier question is critical. So we have to teach our children from young age. There are some programs we are involved with, for instance, in Farm to School program with Dallas ISD, and we plan to do the same with DeSoto ISD as well. So that is one of the challenges. On the production side, because of our climate or our weather, creating climate resilient food systems, gardens or other, is a challenge. So it requires support. It requires policy as well as other creative societal support systems to promote food production and self-reliance or local reliability.
Yeah, thank you. We're out of time. We're all open for questions afterwards, but thank you for my panel, for being here. I'm going to turn it over to Wes.